Okay, we are going to get started. It is 12 o'clock and we'll try to keep on track. So welcome everybody. Happy afternoon. My name is Gladys Pryor. I'm the co-director of community engagement here at Baylor College of Medicine for the Department of Molecular and Human Genetics. This is our very first health professional webinar of the year. So we're excited to kick these off. We hope that you come in and learn some objectives that we're going to share with you, hoping that it can help you in your career, in your dealings with families, and be able to share some of the knowledge that we have for you today. So we do have the genetics webinar series, Fragile X and autism-associated genetic conditions, and you'll see on here a disclosure. And so this session is being recorded. It will be posted online, and you'll get some more information here in a second about that. We only are honoring live attendees for the CEUs. So again, we'll get to how to get your CEUs in a moment. So for social work CEUs, if you are a social worker and would like a free 1-hour CEU, this webinar has been approved for 1 hour by the University of Texas at Austin Office of Professional Development School of Social Work. The views and opinions expressed during this presentation do not necessarily reflect those of the School of Social Work or the University of Texas, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the school or university. Next slide is, okay, so before we start this, these are going to be the 3 numbers that are really important to the attendees. So 50 minutes, you must attend the session for 50 minutes in order to receive full credit, whether it's in nursing, social work, or a general CEU. Within 24 hours of the ending of this webinar, you'll receive an email with information on how to attain your CEUs. So we'll have links, we'll have the presentation slides, and all the information that you'll need, and also contact information for the presenters and myself within that email. So that's how you'll get their CEUs. And then 10 days. So certificates may take up to 10 business days. Hopefully, our utilization of AI and getting things a little more streamlined will get your certifications earlier, but please, with the volume of attendees, it can take up to 10 business days. So, and that's after you submit your survey submission. So, with all that said, I am happy to introduce our presenters for today. Our first presenter will be Holly Harris. She is a committed providing family-centered and evidence-based care for children with neurodevelopmental challenges. She enjoys discovering each child's unique strength while also aiding the patient and family in navigating any challenges or uncertainty that may accompany a neurodevelopmental diagnosis, along with providing diagnostic evaluations and ongoing care if needed. She is additionally invested in research, seeking to broaden understanding of these diagnoses in order to best care for patients. She sees patients for diagnostic assessment at the Mayer Center for Developmental Pediatrics and Autism and serves as director of the Fragile X Clinic at the Mayer Center. Our second presenter will be Laura Buckner, and she likes to introduce herself. And so we will have her do that when it's her turn. So for now, I am going to turn it over to Holly. Holly, would you like to share your slides?
Sure. Just give me 1 second here. And then just a second. Okay, hold on. Everyone seeing them?
Yes, we can see it.
Perfect. All right. Well, thank you so much for inviting me. And thank you for the introduction. Along with kind of my role as developmental pediatrician, conducting diagnostic assessments, I also direct our Fragile X clinic here at Texas Children's. So I'll be talking to you guys today about Fragile X specifically, but also about just other autism-associated genetic conditions in general. Okay. So, my disclosures, I am an author for Up to Date related to autism, and then I am involved in research projects on related to rare genetic conditions, including Fragile X, but none of those directly impact what we'll talk about today. So, my learning objectives for you guys. So, by the end, I would like for you guys to articulate the distinction between an etiologic diagnosis and a descriptive or behavioral diagnosis, to describe some of the key clinical and behavioral features associated with Fragile X syndrome, to demonstrate an awareness of other autism-associated genetic conditions, and then to recognize emerging therapeutic approaches in Fragile X and autism-associated genetic conditions. So it sounds like a lot to take in, but I promise it'll all be doable here in the next 20 to 25 minutes. I initially thought you guys were typing into the chat, but it sounds like it's more just a Q&A function. So you might not be able to tell me your role in organization, but maybe you can raise a hand if you've ever cared for an individual with a genetic syndrome, or an individual with autism, or maybe both. So maybe by show of hands, it's probably going to be most hands. Yeah, let's see a lot. A lot of raised hands. Okay. Um, Yes. And so the first learning point that I wanted to really get across was this difference between an etiologic versus a descriptive diagnosis. And what do I mean by that? Um, it's the answer to this question of why do some, but not all children with a given genetic diagnosis end up having autism? And it's because genetic diagnoses and descriptive or developmental diagnoses are different. So when we think about a genetic diagnosis, we're thinking about something that is based on highly accurate laboratory genetic testing. So you get the report back, and it tells you kind of exactly where the change is, in what gene is involved, and it gives an etiology or a reason for a child's presentation. And it's important because it can also warn us as to other potential medical or developmental findings. On the other hand, autism is what we like to term a descriptive diagnosis, or you might hear others use the term a clinical diagnosis. It's not diagnosed using brain tests or blood tests or brain imaging, but it's rather a clinical diagnosis. It's made by a professional trained in these diagnoses, and it's based on the developmental history provided to you by the parent, or the child themselves as they get older, and observed behaviors that you are seeing during the assessment. So our assessments are often longer in time than a regular pediatric visit, because we are, seeking to observe these behaviors. And the symptom criteria are described in the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders. So this isn't a talk on autism, but just to kind of review so we're all on the same page. If you look at the DSM criteria for autism, it involves two categories. So children and adults with autism have social communication deficits, and they have to have them in all three symptom areas. So difficulties with that back and forth, social emotional reciprocity, difficulties with nonverbal communication, anything from eye contact to gestures, and then difficulty developing, maintaining, and understanding relationships. So that may be kind of making friends, keeping friends, or even kind of taking another person's perspective can be really hard, and kind of understanding what you may or may not want to do in certain relationships. Um, and then the other piece of autism are restricted and repetitive behaviors, and you only need to have two of the four of these. So stereotyped movements or speech, the classic things you might hear about are hand flapping or echoed speech, a need for sameness or routine, a difficulty with transitions, restricted or fixated interest, really getting hyper focused on preferred topics, and then atypical sensory reactivity. So either being bothered by certain sounds, textures, or actually seeking out a lot of sensory input. That either of those can meet that category. And so you can see how children could meet these criteria in a variety of different ways, and how it might depend on how much time is spent with that child and kind of the observer in their interactions. And so some of it, there is a subjective element to all of this. And these symptoms have to have been present from childhood. And then another big key is that they impact one's functioning. We're all neurodiverse, we're all unique, but at what point might some of these specific symptoms, as defined in the DSM, be impacting your day-to-day life? So genetic and developmental or descriptive diagnoses are related, but not the same. So if you have a genetic diagnosis, it's not going to tell us automatically whether or not a child has autism. And then if a child has autism, it doesn't tell us whether that child has a known genetic reason or what we call etiology for that diagnosis. But it should prompt further genetic workup. And that's why one of our kind of best practice universal recommendations is genetic testing. Of course, it's up to a family because sometimes we don't find anything. Sometimes it may not change the treatment or the therapies that we're recommending, but sometimes it does. Harkening back to the earlier slide, sometimes it tells us about things that we should be looking for medically, other co-occurring conditions, and sometimes it just helps a family connect with other families and better understand that condition. And then finally, in this day and age, we actually are moving towards potential therapeutic intervention. So we'll talk about all of those things. But I do want to take a minute and talk specifically about Fragile X syndrome because that is near and dear to my heart. And we do have a clinical program here. So if you know any individuals, patients, families, you can feel free to send them our way. Um, so again, we can probably do this via hand raise. You can't tell me the potential consequences, but maybe via show of hands, have you ever cared for an individual with Fragile X? Great. Um, so Fragile X syndrome, so it is actually considered the most common inherited form of autism and or intellectual disability. And I say inherited because the most common genetic form would be trisomy 21 or Down syndrome, but that is spontaneous. It usually is not passed down through families. It happens spontaneously, whereas Fragile X syndrome is the most common cause of intellectual disability and autism that you might see that has an inherited, that is being passed down through the family in some way. And it involves the Fragile X messenger ribonucleoprotein 1 or FMR1 gene. And just a nugget of information is that gene or the cause of Fragile X syndrome, the fact that involves the FMR1 gene was discovered at Baylor in 1991 by Dr. David Nelson. So Baylor Genetics is amazing and has a very important role in Fragile X syndrome, the work that's been done in Fragile X. And so this gene normally varies in length. So all of us might have a kind of a different number of variants or repeats in this gene. So if you have less than 45 repeats of 3 base pairs, CGG, so if you have less than 45 repeats of that, then you would be considered in the normal range. Then there's this gray zone range that we don't know what to make of between 45 and 54 repeats. And then if you have between 55 to 200 repeats, then you would be considered to have a Fragile X premutation. And so you may know, women have 2 X chromosomes, men only have 1. So there are many women who may be premutation carriers. So they may have this that number of repeats in that range. And if that is the case, there is a risk that their child will go on to have a full mutation so that then their number of CGG repeats in the child will then expand to beyond 200. So if you have more than 200 repeats, then you then have Fragile X syndrome. And so this gene produces a protein that's very important for brain development. And what happens is when you have over 200 repeats, it causes the gene to be methylated and that causes it to be silenced. So the protein does not get produced. So that is what kind of leads to all of the symptoms that we will talk about. So there's some physical and medical implications, kind of see them there. So physically, the child might appear to have large ears or a long face, um, joint laxity, low tone, flat feet, strabismus, which is really just low tone in the eye muscles, but it causes kind of the eye to kind of turn inward or outward spontaneously. Recurrent ear infections can happen just because of the facial structure. High palate, again, part of the facial structure features. And then when males hit puberty, they actually have macroorganism or very large testicles. From what we know, there's no major implications of that other than higher likelihood of torsion, which can be very painful and dangerous. So we always have to tell families to watch out for that. And then in a small percentage, probably 20%, based on the literature that we have thus far, there is a risk of seizures. It usually shows up by early childhood and actually goes away by late adolescence, but that is also a possibility in Fragile X. But really, kind of the majority of the challenges or outcomes that need support are related to development and behavior and cognition. So, the most common finding in Fragile X syndrome is moderate intellectual disability in a young child that presents as global developmental delay. So, if you're working with a child in the early intervention setting, this is going to be a child who is really having delays across all areas, is not walking at 18 months. And you're really concerned that that's not progressing, in addition to having limited to no language. So those are, especially if it's a male child. Females with Fragile X are a little harder to pick up on sometimes because if you remember, we have two X chromosomes. And so therefore, in all of our cells, one of them gets spontaneously kind of shut down or inactivated. And so depending on how many of the mutated X chromosomes get shut down for the girl, then she might present more mildly. But males, you tend to have moderate intellectual disability, ADHD, or some form of kind of inattention, hyperactive, disruptive behavior. Anxiety is a major feature of Fragile X. So a lot of shyness, reduced eye contact, social anxiety, getting a little overwhelmed in social situations. They can be easily overwhelmed by noise or sensory stimuli. You do see some of the hand flapping or even hand biting whenever they're anxious. They can have difficulty with transitions mostly. And again, a lot of this is rooted in anxiety, but you see these features come up. And therefore, you can see, if you're thinking about the autism criteria, why many of them will also be diagnosed with autism. Because if they show these symptoms to a large degree and they kind of meet all of those symptom criteria for autism, then it's appropriate for them to have Fragile X and autism. Okay. I mentioned that third learning objective for you all was to understand other genetic diagnoses associated with autism. And I think my big takeaway here is that we will never be able to know or learn today all of the different genetic diagnoses that are associated with autism. The list that I have here is even just the broad categories. So there are aneuploidies or non-disjunction errors, which are things like too many chromosomes or too little. So trisomy 21, Down syndrome, having an extra chromosome, or Turner syndrome is when a female doesn't have two X's. So those, we have triplet repeat expansions, which is what Fragile X would fall under this category. So when we have those extra repeats and they've expanded a little too far. Copy number variants. So this is when you hear of children or adults being diagnosed with deletions or duplications. So this is when small chunks of the chromosomes are either they have an extra copy or that section has been deleted. And then single nucleotide variants is the fancy way to say that there is just a single change in a DNA base pair, and that has changed up kind of how you're reading that genetic code. So it has implications down the road. So again, not for you to memorize this chart, but this is just an example of one of our developmental pediatrics textbooks and how all these different genetic diagnoses can be associated with autism. And it's because, again, autism is just a description of behavior. So any of these genetic causes or etiologies can result in a child who's demonstrating that behavioral description. So we already touched on, trisomy 21, Turner syndrome, Klinefelter syndrome. So some of these genetic causes have, classic names that they've carried for years. We already talked about Fragile X. There are a lot of copy number variants. Some of you may have worked with children or taking care of children that have some of these: Williams syndrome, Prader-Willi, Angelman syndrome, DeGeorge syndrome, and then at some point there's so many that we don't have kind of names for them anymore, and so we're just kind kind of describing where the deletion or the duplication occurs, right? And so any of these can be associated with autism. I think 16p is one of the more common ones that we find, either deletions or duplications in 16p to be associated with autism specifically. And then, like I said, there can be point mutations, single changes in a variety of genes, and that could lead to a child having a developmental diagnosis of autism. Shank3 is one that's called Phelan-McDermid syndrome, the last one there on the list. Shank3 SYNGAP1 as well. So Dr. Holder at Texas Children's is kind of an expert in these particular syndromes. So, as we're learning more and more, different people become kind of well versed in some of these more rare conditions. But again, might see one child with one of these diagnoses in your entire kind of medical or service career. Okay. And then I want to run us through a case just for some practical kind of reflection and thought about how this might actually present in my clinic, for example. So you're seeing David, he's 4 years, 2 months, and he is sent to us because he's having delayed language, limited social engagement, having some trouble there. Parents have noticed some repetitive behaviors, and then he's just very dysregulated behaviorally. Things make him very upset. He can't calm down easily. So I want you to just think about, if you were there with the family, what other things would you like to know? I know we can't necessarily type them in the chat, but just come to some concrete questions you would be asking, or what things you would want to do next within your practice. So for me as a developmental pediatrician, I'm taking a medical history. And so I learned that really pregnancy and birth were uncomplicated. So this child does have a history of seizures. So they started pretty early as well, 5 months. And they're characterized by brief clusters of flexor spasms. So it's like he's doing a little crunch. And that's kind of how they recognize seizures when he was younger. We call that infantile spasms. And so he's been on medication, and because of the seizures, he got a brain MRI. And so he had an imaging of his brain, and it showed these areas of signal abnormality. So for me, I'm already thinking like there's a couple of other things, going on in the brain, along with his behaviors and his symptoms that might suggest autism. So he looks well. I'm examining him, and I notice these lighter patches, hypopigmented macules, and then he's got like some like a little bit of redness on his cheeks. It's a little bit of low tone, but nothing that suggests one-sided deficit or problem. Um, so if you're in my shoes, would you be considering genetic testing? Kind of already gave you the answer as well, because I already said it's our gold standard recommendation in all children with autism and intellectual disability. But we would certainly consider genetic testing in this child, because there's multiple other things going on that suggest that we might have a positive result. And so this child did go on to be diagnosed with autism based on the social challenges, the language, the repetitive behaviors. And then we were able to find a reason or an etiology for this child. So the testing was positive for a pathogenic variant in TSC2. So this is related to tuberous sclerosis complex. Again, not something you need to know or learn per se, but I just highlight that this is another one of the many genetic conditions. It causes kind of overgrowth. So these tubers that grow in various parts of the body. So the brain, but also skin, heart, lungs, and kidneys. And so this is one where it is important for us to find it and know that we should look at these other areas to see if there's any growth going on in those other areas. But it's also highly associated with autism, but also ADHD, anxiety, intellectual disability. So just an example of how kind of families might come to know that they have a genetic etiology for their condition. And then I'll wrap up now just with a broad overview of research and emerging therapeutics. Because again, there's so many conditions. We can't go into all the different possibilities for families, but just to highlight that it is important to know or to offer families the opportunity to know to find a genetic etiology because there may be eventually a therapeutic intervention and we're moving quickly in that direction. So some children who have a genetic diagnosis can participate in natural history studies. These are kind of harder because there's not a direct benefit, but you're really contributing to just knowledge about a rare condition. So families will come and researchers might, do EEGs or imaging, or I participate in studies of this nature where I'm doing developmental testing and kind of seeing where the children are developmentally depending on their chronological age. And then you kind of track how the disease progresses over time because you have to know how severe are the challenges and what does the disease look like at baseline before the FDA or before we want to start making intervention. We need to know kind of where we're starting from. And then depending on the condition, there may be opportunity for what we call small molecule clinical trials, a fancy way to say like there may be a drug that we're testing or that can work on the pathway specific to a diagnosis. So this is an example of one from the National Fragile X Foundation where there are, it's a phase 2b3. The numbers just mean kind of where we are in the process of drug discovery. So this would be an example of a study where you kind of are passing from we know this is safe and to kind of now is this efficacious or is this going to work? And so we're going to compare it to placebo or people who are not getting the drug that we're investigating. And any of these examples that I'm mentioning are ones that I'm not personally involved in, so then they just serve as examples. But one could go to the Fragile X website and get a whole list of the various trials. This is just one of several small molecule trials. And then, perhaps most exciting when we're thinking about known genetic conditions is that there eventually might be gene therapy approaches. And Baylor's really at the forefront of this at the Neurologic Research Institute and the Department of Genetics. And it's a little blurry, but this is just an overview, like, how would a gene therapy work? You would take, if a person is missing a given gene, you can place it into what we call a viral vector that is not going to make the individual sick, but can carry in the healthy gene and kind of give the individual that gene replacement. This image comes from fragilex.org, but there are many Rett syndrome, Angelman syndrome. There are several diagnoses where there are active gene therapy trials happening now. So it's an exciting forefront for us as scientists and geneticists, but could hopefully make meaningful impacts for children, adults, and families with these conditions. So another plug for a reason to kind of explore genetic causes of autism and intellectual disability. And then this is just my shameless plug for our center and all of our workshops we have here at the Meyer Center. I know you're going to get our contact information, but if you just Google us, these are available to anyone with any type of developmental diagnosis, whether or not you were diagnosed at our center. Our goal is to really provide education to the entire community. Webinars for all the different ages and for new diagnoses, or if you're on a wait list, there's one for that as well. So just a plug for that, my references and my email, and let me stop sharing so that Laura can get going.
And just really quick, everyone, I know there's questions in the comment box. If you could please add them to the Q&A box, that way we can make sure that we're answering questions and not sorting just the comments. So please utilize that. All right, Laura, your turn.
I'm trying to share. There, I think I got it. No, there it is. Maybe. I'll see if it shares.
We can't hear you. Are you?
I'm
Oh, there you go. Sorry.
not muted.
You're good.
It says go to security and privacy screen recording to give permission and start sharing. Do I have to do that? Oh, dang. It needs permission to share my screen. Oh, Lord.
I'll let
Why don't
Chris
you start
answer that
answering
one.
questions while I try to do that real quick?
Yeah, I saw something, someone
Perfect.
asked a question about, so the, if it's recommended for genetic testing for all individuals with autism. And yes, kind of based on, there's a variety of, the American Academy of Pediatrics, College of Medical Genetics, everyone is recommending genetic testing. There actually is, there's a little debate about which one you start with. But that's kind of ever changing as we improve our genetic testing. But yes, we do offer testing for all families and individuals with autism and or their caregiver to do that. Does these children have a process for genetic test? Okay, so great question. Um, we have two routes. So we have a wonderful Department of Genetics where we can refer to those physicians specifically, like the Meyer Center for Developmental Pediatrics. They also have a very long wait list, but that is one option. And I think the benefits of that option are that they are the utmost specialist when it comes to genetics, and sometimes for families. I find that sometimes insurance companies are happier with their recommendation in terms of coverage. That being said, our clinic does use a kind of an outside provider, and it's multiple departments also do it this way as well, where we are able to kind of do saliva swabs in the clinic, and we work with that organization to get the results for families. Surprisingly, Texas Medicaid actually fully covers genetic testing for, and I'm speaking about for autism and intellectual disability specifically, but private insurance, it's not 100% covered, but we can usually give families a quote and they can make a decision about that, or there's some kind of financial support um, ways that the company offers where families can get that information.
Can somebody who has more knowledge than me tell me how to share my screen on a Mac? Because I can't find it.
Yeah,
Who knows how
Chris,
to?
are you able to help?
Yeah, on the Mac, it
Uh-huh.
is very different. So you have
Yeah.
to actually give Teams record your screen security access to do it, which is probably going to make you exit and relaunch Teams.
Oh, well, maybe I should just talk through my presentation and send the handouts. How about that?
Yes, or you can feel free
Because
to
we were running short of time.
forward it
Yeah,
to me, Laura, if you want. I
yeah.
could try to get it pulled up
Yeah.
while you're talking.
I can't talk and pull it up. I'm just going to
Oh,
talk.
okay, sounds
I
good.
I don't know how to fix this. We should have checked it. I'm so
If
sorry, y'all.
if you want to email it
So
to
my
me,
name.
there's still a lot of questions for Holly.
Okay, go
So
ahead and answer questions, and I will email you very quickly. Yeah,
perfect.
thank you, Gladys.
Awesome. So yes, so the process for genetic testing might just depend on the department where the family is being seen. And then how do you get insurance to pay? Yeah. That is also can be challenging. I mean, if you are diagnosing a child with autism, in our experience, that in and of itself should be enough. I think sometimes some insurances may kind of heart or get down to like who is diagnosing, so they might require a neurologist or a developmental pediatrician or psychiatrist, perhaps. I think obviously if you have autism and anything else that's co-occurring, any other medical co-occurring conditions, any type autism plus intellectual disability. So, anything else that's going on, if you could include that in your notes, or then that might heighten an insurance willingness to cover the testing for autism. Are there other questions that I missed? I'm just realizing I couldn't see the chat myself when I was talking, but you guys are very participatory. I appreciate it.
There's a few in the Q&A. I'm not sure
Oh,
if you answered those.
oh,
If
yeah,
you
nope.
click
I
on
had
that
not
Q&A.
clicked. I had not clicked on the Q&A. Okay, it's
Perfect.
thinking coming up. Currently applying. Okay. Oh, if there are any genetic counselor, or if we work with genetic counselors in our practice, we would love to work with genetic counselors. So I will say when we go through other companies that if we outsource our genetic testing, they hire genetic counselors who we're able to access for our families, which is wonderful. So if we haven't gotten to, if we feel like we haven't gotten to do a full comprehensive pre-genetic testing counseling, we can say, hey, first let's talk to the genetic counselor through this organization, and then they'll send out the testing to your home, and then you can send it back in. And genetic counselors can help us if we get positive results. The Department of Genetics obviously has genetic counselors in-house, and they're doing a ton of the care for families, and getting to kind of provide that face-to-face at the clinic in the Department of Genetics. Son is SCN2A, aside from our ooh, oh, okay. Neuro, yours was covered after a seizure. Yeah, so this child had autism, but then also a seizure. And SCN2A. So, oh, I don't want to misrepresent, but I think that you saw my email on the screen, holly.harris@bcm.edu. I want to say that we have a geneticist here who's particularly interested in SCN2A. So I'd be happy to, I have a name in mind, but don't want to say something incorrect. So I'm happy to reach out to that person on your behalf. And because I think it's good to know kind of, that person would have seen the highest number of patients and really be able to give you some guidance. And then our center, like I mentioned, the Meyer Center for Developmental Pediatrics and Autism, you are free to attend any of our workshops, and those are kind of more practical. So, what do we think about ABA therapy? How do we access therapies? What might be some of the things that we run into in the school system? What are some other state-based resources? So those would be covered in our new diagnosis workshop, and you're welcome to attend, even if you were diagnosed elsewhere. So again, you can email me and I can kind of plug you in with that. It's also on our website. Options for families for under or uninsured. So if it's Medicaid, like I said, that surprisingly we get good coverage. With no insurance, there is something called Texome, Texome. This is a project run by Dr. Wangler at Baylor Genetics, and it is specifically kind of trying to increase opportunity for genetic testing for underrepresented patients and those that have trouble with access. So there's a little bit of a criteria for that process. Like I think you have to have maybe autism plus some other conditions, but I think they maybe even expanded it to just autism or just intellectual disability. I wish I had the exact website, but I'm hoping if you Google Texome, Texome, then it would kind of show you that process. What ages do you see? Does therapy help adults? Oh, so we're 12 and under at the Meyer Center, which is a little unfortunate, but I think it's largely due to kind of our insurmountable wait list. And our hope is that if they're 12 or older, they're either mild or they found support through school or outside. I will say that UT has a clinic, the CLASS clinic, run by Kathy Loveland, who does diagnose teens and adults. Thank you for the link. And then so that could help with diagnosis. And I think therapy helps everyone. Now, for adults, often we're looking at, depending on whether or not depending on intellectual ability, we're looking at maybe behavioral therapy, or it might be something like CBT, cognitive behavioral therapy, the same thing we use for those who have anxiety, or it really just kind of orients us to our thoughts and our feelings and kind of where those are coming from and when they might be, might not be correct, or what we can do to kind of cope with, feelings or thoughts that we might be having that need to be maybe changed or reframed. So anyway, I think therapy does help adults, and the type of therapy just depends based on kind of that individual. I think I got everything. Maybe I got everything in the Q&A. I'll hop back to the chat. Hopefully. Oh, nice. Yeah.
I did receive her presentation, so let me upload it.
Awesome. Yes. And our services are covered by insurance. Yes.
I hate Teams. I can just say that out loud now. I hate Teams.
Oh.
I'm so familiar with Zoom. I apologize, y'all. So I'll introduce myself. My name's Laura Buckner. I am a licensed professional counselor. I'm a former special educator. I like to say my most important degree is my MOM degree. Parent of a 36-year-old young man. with tuberous sclerosis complex, mentioned by Holly just shortly ago. A rare genetic condition we don't carry the gene for. And he was diagnosed when he was 3 months old with infantile spasms, back before they had a gene marker. So we went years not knowing if we carried the gene. We don't. But somebody asked, should you get a genetic testing if you have autism? You know, my son's disease causes significant kidney disease, of which he is affected. And if he only had an autism label and we didn't know about tuberous sclerosis, we could have missed life-threatening kidney disease. So that's just my perspective. Go ahead, Gladys. Thanks. So I'm going to scoop on. Just know that there's a wide variety of spectrum disorders, and autism is considered a spectrum. You hear people say he's on the spectrum. It's not a one-size-fits-all label. Go ahead, Gladys. So it affects a lot of things. It's not like the colored tab at the top is what people think autism spectrum looks like. If you're lower to the green side, you have less autism. If you're on the red side, you're more autistic. Actually, it looks like the circle below, where it affects all of those areas in a variety of ways. Next slide. And your job as a family member or the person supporting the family is to help the family become an expert on who this child is outside of the diagnosis, and to believe in what's possible, to have hope. Thanks, Gladys. Next slide. So when there's autism involved, communication is a big deal. And so you can back up one. I lost it. There it is. So some visual supports, just using spoken language, even if your child is not speaking back. I remember early on, my child was very long in developing spoken language, but we were taught if he could say one word like juice, he would say juice a lot. We would say, I want a juice. Would you like a juice? Let's go get a juice. And repeated full sentences because he's hearing spoken language repeatedly. And then using gestures, sign language if you want to try and involve that, even facial expressions of body language. Experts in the autism field recommend people use what they call the 6-second rule. If you ask a child with autism a question, wait for about 6 seconds to give that child time to process that information and come up with their response. It may even take longer than 6. Next slide. Some other supports that can help are augmentative or alternative communication devices. Low tech would be a picture board or a communication book. A lot of people use what's called social stories, and if you Google social stories, you can find it. There's a lot of ways to do it. A middle tech would be something with a limited number of voice output buttons that can record messages, or high tech. A lot of people with autism are using iPads or iPhones or other complex communication devices. Next slide. You should be aware that a lot of people with autism and the label of autism can be what they call sensory defensive, or may even be diagnosed with what they call a sensory processing disorder. It was certainly true of my son. And what is it? It's an overreaction that the brain perceives as threatening. It might be a sound, it might be a smell, it might be a touch. I used to tell teachers, don't touch my son gently. Touch him with a very firm touch, or he'll react. It could be a taste, it could be something they see. A lot of people with autism are bothered by fluorescent lights, for example. Next slide, or flashing lights. So what would you see if somebody was experiencing sensory defensiveness? They would probably attempt to minimize whatever sensation they're having by withdrawing from that situation, and a variety of ways how they would withdraw. They might cover their ears, close their eyes, push a person away, or even respond aggressively if somebody's touching them, for example, crying, run away, refusing certain types of clothing. For a lot of people, tags in the back of clothing are a big issue. And so a lot of people remove tags. I was one of those people. An overreaction to touch or sensory seeking, chewing on things. We used to have rubber straws my son would chew on all the time. I remember years ago, he would wake up in the middle of the night screaming, crying, and talking about a monster in his room. And we thought it was nightmares. But one day we were out in the front yard, and I live in East Texas, where there's a lot of oil oil business. And we have an oil tank battery behind our property that when it cranks on, it makes a really, really, really loud noise. And it goes on for like 15 minutes. We were in the front yard, and my son, that thing cranked on. We hear it, no big deal. And it was during the winter where there were no leaves on the tree, so it was louder. My son covered his ears and went running into the garage yelling, "The monster, the monster." That's what he was hearing. Next slide. And so identify the triggers. You know, with that monster trigger, we went a long time thinking it was a nightmare because we were hearing that sound, but it didn't sound like a monster to us. You might have to really do some careful observation over time to figure out what's causing that trigger, what's triggering that overreaction. You can help by creating quiet spaces. Use tools like a lot of people with autism like to use headphones to block out loud noises. A lot of people have very sensitive ears, like my kid. Weighted blankets or vests are calming, or even fidget toys. And then you also want to teach skills. Teach these kids or these adults how to emotionally regulate themselves when something triggers that scary response. But really important, don't attempt to stop or eliminate the behavior because the behavior is communication. And this person's trying to communicate something. So instead, teach coping strategies. Next slide, Gladys. Thanks. I think this is such an important quote. The essential function of challenging behavior is to communicate to adults that a kid does not possess the skills to handle certain demands in certain situations. And unfortunately, and you all probably know this as well as I do, many, many times kids in schools, kids in homes, even adults with autism are labeled with challenging behavior. And then most of what's done to deal with the challenging behavior is focused on eliminating the behavior, stopping the behavior, punishing the behavior, instead of asking ourselves, what is this behavior trying to communicate to me? And how can I help answer the issue that is being communicated to me through this behavior? Thanks, Gladys. Next slide. Lots to consider beside the medical concern. And so where should you start? If you're dealing with somebody with autism and a genetic condition, perhaps that has communication issues, a speech therapist is your first stop. If there are sensory concerns, an occupational therapist is your first stop. And don't wait. A lot of people wait on kids, especially with autism labels. They'll wait for kids to learn to speak for years. And a lot of time is lost. Children need to be able to communicate. And if they can't communicate verbally with words, spoken words, get them a way that they can communicate, because not being able to communicate can be a huge source of challenging behavior. Next slide. And remember that a disability label is only a medical diagnosis. Autism is only a medical diagnosis. A doctor has to give it. All of these other genetic conditions are medical diagnoses, and I call them your passport to services. Next slide. You only pull out your passport when you need to cross a border. I live almost to Louisiana. I'm an hour from Shreveport. I don't need a passport to cross the state line. But if you're talking about a child or an adult who needs medical help or Medicaid waiver services or Social Security benefits or speech therapy, some kind of service, that's when you pull out that passport. You only need the disability label when you need a service. Think of it as a passport to service. A lot of families pull out their passport, and even professionals, they'll pull out that passport every day like it's the answer to who this kid is. It's just a passport to services. That's all it is. Next slide. This was what our neurologist said to us the night he diagnosed our 3-month-old son with tuberous sclerosis complex. And it is a scary diagnosis. But he said, this child will be as disabled as you choose to see him. And in hindsight, 36 years later, I am astounded by the brilliance of that statement. You know, I don't know that we fully understood it 36 years ago, but what it meant was we have to see our child for who he is beyond tuberous sclerosis complex, beyond autism, beyond medical concerns. because he is a person. And I will tell you right now, he is at his workplace, Habitat for Humanity Restore, where he has worked for 12 and a half years, and he drove himself there in spite of tuberous sclerosis complex, intellectual disability, autism, anxiety, all of those things that go with that label, because we saw who he was and what he was capable of, and we built on every skill we could find. So this is an important quote to share with families. Next slide. And then if you're not familiar with Medicaid waivers, get familiar really fast and help people get on the list. I'm just going to say the Health and Human Services website is really difficult for families who have no idea what a Medicaid waiver is. I send people to Navigate Life Texas. It's a website called Navigate Life Texas. And this link in the handout or in this PowerPoint takes you right to the slide about, or the information about Medicaid waivers. It has a video of a mom talking about what a Medicaid waiver is, and then all the information you need for helping people get on a Medicaid waiver wait list. And I will tell you, unfortunately, in Texas, the wait for Medicaid waivers, and Medicaid waivers can provide, it might provide home modifications, it might provide physical, speech, occupational therapies, it might provide music therapy, hippotherapy, it might provide medical help, it might provide respite care, attendant care, but the wait for a Medicaid waiver in Texas is 12 to 18 years. So we don't have time to wait and see if this child is going to need a service. Go to the next slide, Gladys. To get on the list, you don't have to qualify. You just have to tell people, you have to tell the Health and Human Services this information: the child's name, their date of birth, their social security number, demographic information, and a brief 12 to 15 healthcare questionnaire. Then you get an ID number. Keep track of that, because if you lose it and maybe you move to a new location, Health and Human Services can't find you, you come off the list. And you can go to yourtexasbenefits.com to update any kind of information and keep track of details regarding your child's case. I tell professionals all the time, don't just hand this information to a family member and say, you need to get on this waiting list immediately. Make the call with them. It only takes 15 minutes. Parents are often so dang overwhelmed. They don't know what a Medicaid waiver is. They don't know what it means when they ask these questions, and they don't follow through. And the wait is 12 to 18 years. So we can't afford to wait. Next slide. There's some phone numbers about getting your child on the interest list. I'll leave it there and go to the next slide. Bottom line, cultivate hope. No medical diagnosis, no genetic diagnosis, no label of autism predicts a future. Hope is a huge driving force. Next slide. And I'll close with that. Whew, that was fast and furious. Sorry for talking so fast, but I want to leave time for any questions that might be out there. So, and if you want to back up Gladys on that slide, they're wanting those phone numbers again. Any questions because I haven't been watching chat. Is there anything I need to answer or that Holly needs to answer?
Yeah, there's actually quite a bit.
Okay.
Even in the Q&A, there's a lot of questions going on there. So let's see. Yes, these presentations will be shared. So at the beginning of the presentation, I shared that tomorrow. So within 24 hours, we will be sending an email that tells you how to get your CEUs. It will have contact information. It will also have these presentations in it. So we will have that available for you tomorrow. Texum, oh, Holly, you answered that question.
Yeah, Texome is more of it's a Baylor, a team honestly of multiple researchers, but that one's more for kind of finding ways to get genetic testing for individuals without insurance. I mean, those with insurance can also be a part of Texome. But the class clinic there was some questions about like adults or adolescents or kind of our age cutoffs for the older individuals who might have a concern for autism. The UT probably has the most experience in that area.
I saw a question in the chat about any ABA thoughts or feedback. And the only thing I can say, ABA has a lot of mixed reviews in the autism community. I have known ABA therapists who are stellar and really, really good at what they do. But I also have known a lot of adults with autism who say that was their worst nightmare. And so I would be very cautious and do a lot of research and talk to your medical professionals or your other professionals involved before you just dive right into ABA. It can be a really useful thing, but a lot of it will depend on who you get to do it. Holly, can you say anything more to that?
100% agree. And you know, I mean, that's our primary recommendation often. It is our most evidence-based recommendation, right? But evidence is based on like the highest quality provision of ABA. So you do have to be careful and trust your instinct as a parent, right? When you're evaluating ABA programs, because it is also a company or a business. So there's competing priorities. And so I think you just if it's done well, it can be extremely beneficial way to learn. It focuses on building skills. So what skills are important to the child and to the family? And it's not trying to build skills that are, oh, we just want it to be this way. It's no, what is inhibiting them to having the best life possible? What skills are needed for this child, and then trying if they're maladaptive behaviors or things that are really harming the child or kind of inhibiting them from moving forward, how could we redirect from those, or how can we teach other strategies to replace those? So it can be really helpful and if done well. And so we do always recommend it, but it can be overwhelming to find somewhere, and there's long waiting lists regardless. But
Well, and there's a
especially
couple
in
of
very young
comments in the
children, we find it to be extremely effective. And there is evidence that it improves kind of those daily living skills and
there's a couple
learning
of
and
comments.
cognition.
I'm sorry. There's a
Yeah,
couple
go
of
ahead.
comments in the chat from ABA, an ABA provider. And she said, all of that's very true. It can really depend on the provider of the therapy. My bottom line, I would say, if this is a therapist who's just trying to eliminate behavior and it's punishing, then I would go in another direction. Behavior
Yeah.
is communication. You can redirect, but punishing doesn't work. Been there, done that.
And also we like to tell our families we want your ABA therapist. I love that there's like a BCBA here, because right, we want your team to be communicating with you, and to there should be an element of parent consultation, and if your child is going into a clinic for their ABA, so that they can tell you what they're working on and how you can do that at home, right? Because that's the child's still going to spend the majority of their time at home, and so parents need to be very intimately involved in kind of knowing what's going on with the behavior, and how ABA therapists are helping and what they can be doing at home. Another big thing is that the science of ABA is very scientific, and it's very data driven, which of course I'm a scientist. I like, because your therapist should be tracking whatever you've identified as a skill or a behavior that you're wanting to work on, the occurrences of that over time. And so it is very individualized. You're not just kind of in with a group and everyone's getting the same thing. It should be very individualized based on your child, and you should be seeing changes in those shared goals.
I'm going to switch gears because I don't want us to lose sight of what Gladys has on the screen here, the upcoming webinars. But I want to call your attention to the last one that will be on April 15th. TAND stands for Tuberous Sclerosis Associated Neuropsychiatric Disorders. What a mouthful. But I will tell you that my son and I drive 6 hours each way to Memphis and back every year to see a TAND specialist. And she has been miraculous in helping us with the anxiety, the autism-like symptoms. And so I would really encourage you, if this has been interesting to you, it is going to be more focused on TAND, but she has a lot of good information to share. And like I said, we go 6 hours each way just to see her.
Thank you, Holly and Laura. Really appreciate you sharing all of your knowledge and information that you have. Obviously, there's a lot of questions, and everyone is very interested in these topics. Again, we will be sharing within 24 hours. We will send out an email that will have the presentation slides. It will have contact information for both Holly, Laura, and myself, and it will have your CEU link to be able to complete those surveys and receive CEUs. Again, it's your CEU certification may not be available until 10 business days after you complete the survey. We try to get them as fast as we can, but of course, with this many people on the call, it can be a little difficult. So be patient with us, and we will get them to you as soon as we can. Thank you so much for attending this webinar. Like Laura said, we have 3 more webinars coming up. February 18th, we have updates on Angelman syndrome. March 18th, genetic metabolic disorders. April 15th, TAND. And so we will have those available as well for CEUs. So we will have those links to sign up for those webinars as well. And we'll email all that information to you hopefully soon. Thank you again, everyone. I appreciate your time, and have a great rest of your day.
Stay
Thanks
warm.
all. Yeah, such
Yes,
good
stay
questions.
warm.
Thank you, everybody.